good question, and I think it's a fear that a lot of people have when we're looking at changing models of care. I guess the specialist cancer nurse plays a key role in this study, and probably their biggest role is in developing a survivorship care plan for the patient. So that survivorship care plan has quite a few really important key pieces of information. So they'll be developing a treatment summary and also some self-management goals, which is defined by the patient. But the third really important thing is the follow-up schedule that's included in that care plan. So that care plan will be given to a number of key stakeholders in this study. So the patient is probably the most important one that gets that. And so we're really advocating patients to take an active role in their follow-up and make sure that they are meeting those requirements that are the due dates that are given to them. That follow-up schedule also will be given to the patient's GP, and that's a really key part. The specialist cancer nurse will be phoning the GP and outlining exactly what is due and when, and who will be providing that service. So the specialist cancer nurse is the conduit in this. She or he is the one that's really, the central contact person. But the responsibility of each element of their follow-up care really falls on the members of that multidisciplinary team that are responsible for it. And that's why it's so important in that follow-up schedule that we outline who the provider is that's providing that service and at what time point. This is a national study and every service is going to be different. So the idea is that this can be flexible to fit in with each different specialist centre and each GP clinic, how they operate. We have a standardised follow-up schedule, which there's I think more information about that available on the website. But the key is that the patient is receiving care at certain time points. So it's really a discussion between the specialist cancer nurse and the GP to find out who will be doing what and the agreement of who is taking responsibility at which time points. There might be some situations where a patient doesn't require imaging if they've had a mastectomy or a bilateral mastectomy, and it's decided that their risk is so low that there's no need for that. This isn't rigid, and that's the key here, is that it's patient focused and we can adapt it to what the patient needs. In some settings it might be the GP that's ordering their bone mineral density, for example, whereas in a different setting that would be something done by the medical oncology team. And we have the ability to be flexible with this, and the specialist cancer nurse will have knowledge of those processes, and they'll be the one that really makes that nice and clear in the survivorship care plan. Specialist cancer nurse will be asking the GP about their recall processes. So we realise that each GP clinic operates differently, and some will have the ability to recall patients. For example, if we say the patient needs to be seen in June annually at a minimum, we can put that process in place for the GP to recall them then if the patient hasn't self-initiated those appointments. Not every GP practice will have that service available, but certainly if they do, that's something that the nurse will be advocating for. So the specialist nurse, if there is a practice nurse available, and again we have to be flexible because not every GP clinic will have that available, but the practice nurse has a very key role. We have to appreciate their expertise and knowledge about chronic disease management and their involvement in creating CDM care plans and assisting GPs with that. So I think really drawing on their existing knowledge is an important part, but really outlining to them what we expect the patient to potentially have problems with and what the patient has outlined as what they want to work on, and then working with that practice nurse to fill in any gaps that we can. So they will obviously also have access to that survivorship care plan, which will have lots of links to all different sorts of information for them. So just pointing them in the direction of that, but also encouraging them to give us a phone call as well, where they're as the conduit really between the GP clinic and the specialist centre. So we really encourage that they get in touch if they've got any questions moving forward. So the key to having a nice, clear and concise survivorship care plan is to start that communication nice and early. We know that when patients are involved with multiple teams within one service, that they're coming back and forth to lots of different appointments. And if we have knowledge that they're involved in this study and we can have some clear documentation about what that particular patient needs for their follow-up care, that is really important information to then include in our care plan. So having those discussions early on with each clinician that's responsible, for example, medical oncology, radiation oncology and your surgical team, making sure that they're all aware that the patient is on this study and we need some clear, concise follow-up requirements. That's really important to start that early.